Imagine you're gearing up for surgery.
Yeah.
Your mind probably jumps straight to the operation, right? The recovery.
Yeah.
Maybe what shows you'll binge watch after.
Right.
But have you ever really thought about the incredibly detailed stuff that happens before you even get near the operating room? It's like this secret mission control for your body, making sure everything's, green for launch. Today, we're doing a deep dive into exactly that phase. Preoperative evaluation for non-cardiac surgery. We're pulling back the curtain on what actually goes on, why it's so critical for your safety.
And that's really where the internist often steps in, acting almost like a medical co-pilot. You see, the surgeon, they're focused on the how of the operation, the technical side.
Right.
But the internist, we're the medical gatekeepers, asking, okay, are you medically ready for this? It's not just a quick check. It's a really thorough look at your overall readiness. It allows for, truly shared decisions, understanding the specific risks for you.
Makes sense. So our mission today is to unpack all those pieces, medication changes, those subtle heart risks, and even how just like walking upstairs can tell us so much about how ready you are for surgery. It's all part of getting that final all clear.
Okay, so let's jump right in. When someone comes in for that pre-op evaluation, what's the internist actually doing? What's the main job?
Well, the objectives are pretty straightforward, but getting there can be complex. Essentially, we have a few core jobs. First, assess your personal risk, especially cardiovascular risk and what we call functional status, basically how well your body handles activity.
Okay.
Then we have to weigh that risk against the specific surgery you're having. Knee surgery isn't the same risk as open heart surgery, obviously.
It's different demands. Exactly. Then we figure out if any more testing is needed. And crucially, advise on medication adjustments. The whole process involved looking at your history, meds, doing a systems review, an exam, and using these risk prediction tools. And this is really important. If we find something new or unstable, maybe new chest pain or shortness of breath you haven't had before, then elective surgery gets postponed. Simple as that. We need to figure that out first. You wouldn't launch with a warning light flashing, would you?
No, definitely not. That makes total sense.
Yeah.
So speaking of potential warning lights, medications, that seems like a really tricky area. How do you decide what stays, what goes?
It really is fascinating. And honestly, a lot of what we do isn't based purely on massive double-blind trials. It's often more about accumulated clinical wisdom, common sense, and just prioritizing safety.
So experience plays a big role.
A huge role, especially because the science is always catching up, But we have to make decisions now to keep you safe during surgery. It's kind of the art of medicine meeting the science. Okay, so let's talk specifics. Antihypertensives, blood pressure meds, generally. Keep taking them.
Okay.
But diuretics are often held the day of surgery. The worry is low blood pressure or low potassium, although, interestingly, the data isn't super clear that continuing them actually leads to worse outcomes. ACE inhibitors and ARBs. We used to hold them, but now it's generally considered okay to continue them. Long-term outcomes don't seem worse if you do. And beta blockers, this is key. If you're already on them, you absolutely keep taking them. No question.
Got it. What about diabetes meds? That seems complex.
It is a real challenge. Oral hypoglycemics, hold them on the day of surgery. Then there are the SGLT2 inhibitors, drugs like canagliflozin. They need to be stopped 3 to 4 days before surgery. There's a risk, rare but serious, of something called ketoacidosis.
Okay, 3 to 4 days. That's important lead time.
Exactly. Basal or long-acting insulin might be continued, maybe with a slight dose reduction if you're prone to lows. But prandial, the mealtime insulin, that gets held.
And what about those newer weight loss drugs, the GLP-1s, like Ozempic?
Yes. Those bring a different concern. Delayed gastric emptying. Basically, food stays in your stomach longer.
Which increases aspiration risk, breathing stomach contents into the lungs.
Precisely. Which is very dangerous during anesthesia. So the current thinking, largely cautious and not strictly evidence-based yet, is to hold daily versions on the day of surgery and weekly versions for a full week before. Safety first.
Makes sense. Any good news on the medication front?
Yes. Statins. If you're taking statins for cholesterol, keep taking them. There's actually growing evidence they might be protective during surgery. For some high-risk stuff like vascular surgery, we even consider starting a statin beforehand.
Interesting. How about aspirin?
Aspirin. It depends. If you don't have coronary stents, continuing, it might be reasonable if your heart attack risk is higher than the bleeding risk for that specific surgery.
Yeah.
But that's always a detailed chat you need to have with the surgeon, too.
Okay. Any other big ones to mention?
Definitely. Steroids, like prednisone, if you're on a regular dose, continue it. You might even need extra stress Steroids, depending on your dose, how long you've been on them, and the surgery itself.
Right, because your body might not make enough stress hormone on its own.
Exactly. And don't forget over-the-counter stuff and supplements.
Okay.
Crucial to ask about these. NSAIDs, like ibuprofen, thin the blood. Some herbals interact with anesthesia, you'd be surprised.
Yeah, people might not even think to mention those.
Right. And finally, tobacco and alcohol. This is a key moment for intervention. Quitting smoking, ideally at least 4 weeks before, makes a huge difference in complications. And addressing heavy alcohol use or drug abuse is vital because withdrawal during or after surgery can be really dangerous.
Wow, that's a really comprehensive rundown. Seems like managing meds is a major part of that pre-op mission control.
Absolutely. It's one of the most critical areas where we actively manage risk before you even get to the OR.
You mentioned beta blockers earlier and how important it is to continue them if you're already on them. But it sounds like their overall role in surgery has been, well, a bit of a roller coaster.
Oh, absolutely. A fascinating journey, really. The understanding has shifted quite dramatically. Initially, the good story was very strong. Early studies, mostly observational or smaller trials, showed really impressive results like big reductions in deaths and heart attacks when beta blockers were given around the time of surgery, especially for patients who already had heart issues.
So what was the thinking there?
The idea was they counteract that surge in stress hormones, the sympathetic drive that happens during surgery, keep the heart rate down, blood pressure stable. Makes sense, right?
Yeah, seems logical.
But then came the bad side. Larger, more rigorous trials started painting a different picture. Not all studies confirmed the benefit, and some even hinted at harm, especially if given to lower-risk patients. The real game changer was the POISE trial. It was huge. It found that giving high-dose, long-acting metoprolol did reduce heart attacks.
Okay.
But it also led to more overall deaths and more strokes, mostly because of problems with hypotension, blood pressure dropping too low.
Whoa, so not so straightforward.
Not at all. That really forced a rethink. It showed that just giving everyone a beta blocker, especially starting it right before surgery at high doses, wasn't the answer and could actually be harmful. So the guidelines today are much more nuanced. Rule 1. If you're already taking them, continue them. Period. Stopping is risky.
Got it. Don't stop.
Rule 2. If you're not already on them, they're generally only considered if you have known significant heart ischemia risk, or if you have 3 or more specific risk factors, things like diabetes needing insulin, heart failure, known coronary artery disease, prior stroke, kidney disease, or if you're having very high-risk surgery.
So a much more targeted approach.
Exactly. And critically, you should not start them on the morning of surgery. Ideally, start them more than a day, preferably days or weeks before, so we can see how you tolerate the dose and avoid sudden blood pressure drops.
It really highlights how medical advice evolves with evidence. Are there other pre-op areas where the thinking is still actively changing like that?
Oh, definitely. Like we touched on with the GLP-1 agonists, we're still learning the best way to manage those around surgery. The use of routine cardiac stress testing before surgery is another area that's become much more selective based on evidence. It's a constant process of learning and refining.
Okay, so moving on from meds.testing. We often think, more tests equals safer surgery, but I've heard that might not always be true, that routine tests don't always help.
That's a really common assumption, but yeah, it's often not the case. It begs the question, when does a test actually provide useful information that changes what we do? The surprising bottom line from a lot of research is that routine preoperative testing in patients who feel fine, who are asymptomatic, rarely improve surgical outcomes.
Really? Even basic stuff?
Even basic stuff. Think about something like cataract surgery, very common, generally low risk. Studies have shown that doing a battery of routine tests beforehand doesn't actually reduce complications. More tests don't automatically mean better care if they aren't targeted.
Okay, so what about specific tests? Like EKGs. Does everyone need one?
Generally, no. Routine EKGs aren't usually helpful for asymptomatic folks having low-risk procedures. We might consider one for higher-risk surgeries or if you have known heart disease or vascular disease already.
What about an echocardiogram, an ultrasound of the heart?
Also not routine. We'd think about it if you have a known history of congestive heart failure and haven't been checked out in over a year. Or maybe if you have known significant valve disease and haven't had an echo recently. But not just for everyone.
And coronary angiography, looking inside the heart arteries.
Definitely not routine for pre-op screening in asymptomatic patients. Angiography is for diagnosing chest pain or known severe disease, not for general surgical risk reduction.
Okay, that covers the heart tests. What about non-cardiac tests, blood work, chest x-rays?
Similar story, really. Little evidence for routine benefit. A chest x-ray, generally not needed unless you have chest symptoms, known heart or lung disease, you're having chest surgery, or maybe if you're over 70 and haven't had one recently.
And blood tests, like a CBC or metabolic panel.
Those are often ordered almost by habit sometimes, or for specific reasons like a CBC if you're over 65 or we expect blood loss, or checking kidney function if creatinine might be high. But they're routine value in healthy, asymptomatic patients. Honestly, it's uncertain. The key principle should be, will this test result actually change how we manage things or significantly improve safety? If not, it might be unnecessary.
That's a really important filter. Will it change the plan?
Yeah.
So clearly the heart is a big focus, but it's not the only thing, right? What other systems get scrutinized in this pre-op check?
Absolutely. While heart problems drive a lot of the mortality risk, lung issues, pulmonary complications are actually the most common cause of problems after surgery, the morbidity.
Okay. So lungs are a big deal.
Huge deal. So we focus heavily on things like smoking cessation. Quitting 4 to 8 weeks before is ideal. If you have COPD, we want your breathing optimized, usually with inhalers. And here's something interesting. Low serum albumin, a protein level in your blood, less than 3.5. That's actually a surprisingly strong predictor of lung complications.
Really? Albumin? Why is that?
It's not just about nutrition. It often reflects your overall physiological state, maybe underlying inflammation or just lower reserve. It's like a quiet signal that your body might struggle more post-op.
Fascinating. What else?
Obstructive sleep apnea, OSA. That increases risk, too, for heart attacks and cardiac death after surgery. We're still figuring out the best interventions to reduce that specific risk, though. Beyond lungs, we look for active infections, a UTI or respiratory infection. That'll usually postpone elective surgery. We check your hematologic history, any clotting problems, bleeding disorders, past transfusion issues. Endocrine system is key, too. Are you on steroids? We need to know about potential adrenal suppression. Is your thyroid okay? Is diabetes under control, especially if you're on insulin? All raise risk if not managed.
Okay.
Then there's renal function kidney problems like creatinine over 2, that's a known risk factor, and neurologic history like prior strokes. And just generally, we ask about any past problems with anesthesia for you or your family. And for women, we need to rule out pregnancy. It's a pretty wide net we cast.
It really is like detective work. Trying to find any potential weak spots before the mission. So, zooming back in on the heart, what are those absolute showstopper conditions, the red flags that make you say, hold everything, we need to deal with this first?
Right, these are the active cardiac conditions. If we find these, elective surgery is off the table until they're stabilized. Think of them as critical system alerts. First, unstable angina or severe angina. If you're having significant chest pain symptoms, that's a definite pause. Second, a recent heart attack, MI. Generally, you need to wait at least 60 days after an MI before elective surgery to let the heart heal.
60 days, okay.
Then having stents put in, PCI. This timing is crucial. Balloon angioplasty only. Wait 14 days. A bare metal stent, wait 30 days. A drug-eluting stent, the common kind now. The ideal wait is 6 to 12 months.
Yeah, that long.
Ideally, yes. Though sometimes 3 months can be considered if delaying surgery is riskier than the stent issue. Why the wait? It's all about letting that stent heal into the artery wall and giving you time on crucial antiplatelet meds to prevent clots forming in the stent, which is called stent thrombosis and can be catastrophic.
Makes sense. What else stops the clock?
Decompensated heart failure. If your heart failure isn't well controlled, surgery waits. Symptomatic severe valve disease. If a bad valve is causing symptoms like shortness of breath, it likely needs fixing before the other elective surgery. And symptomatic arrhythmias. Irregular heartbeats causing problems. Need to sort those out first. And one really key concept. We don't do bypass surgery or stents just to lower the risk for some other unrelated surgery. There's no evidence that strategy actually helps, and it carries its own risks.
That's a really important point. So you fix the immediate unstable problems first. I can imagine telling a patient their surgery is postponed. Must be tough sometimes.
It can be. People get mentally prepared. They arrange time off work. So disappointment is natural. But once we explain why, that it's purely about making the surgery much safer for them specifically, most people understand and appreciate the caution. It's about prioritizing their long-term well-being over a specific date.
Right. Safety first. Okay, shifting gears slightly, you mentioned functional status earlier. How something as simple as climbing stairs can tell you a lot. Can you unpack that a bit more? How does that work?
It's honestly one of the simplest yet most powerful tools we have. We use this concept called metabolic equivalence, or METs.
METs.
Yeah.
Yeah.
It's a way to standardize how much energy an activity takes. We can estimate your MET level just by asking about your daily life. No fancy tests is needed.
Yeah.
So one MET is basically just existing, resting, eating, getting dressed, maybe walking slowly around the house.
Baseline.
Exactly. The magic number we often look for is 4 METs. Can you do activities that require about 4 METs of energy?
And what does 4 METs look like in real life?
It's things like climbing 1 flight of stairs, walking on level ground at about 4 miles per hour, doing heavier housework like scrubbing floors or vacuuming vigorously.
Okay, so fairly normal daily activities for many people.
Right. And if you can do 4 METs worth of activity without getting significantly short of breath or having chest pain, that's generally a good sign. It suggests your heart and lungs have enough reserve to handle the stress of many surgeries. If you can do more than 10 METs, strenuous sports like singles tennis, swimming laps, that's excellent capacity.
So why is that 4 MET threshold so important?
Because studies have consistently shown that if you can't reach 4 METs, if you get symptoms just walking up 1 or 2 flights of stairs, your risk of complications during and after surgery goes up significantly. It's a really potent, independent predictor of risk. A simple question with profound implications.
It really is amazing how everyday life reflects our internal readiness. So we've talked patient factors, meds, heart, lungs, METs. But the surgery itself matters too, right? Knee surgery isn't the same as brain surgery.
Exactly. The procedure itself carries its own inherent risk level. We now tend to categorize surgeries into 2 main buckets based on cardiac risk. First, low risk. These are procedures with less than a 1% chance of a major cardiac event, like a heart attack.
Okay, what falls into that category?
Things like endoscopic procedures like colonoscopies, superficial skin surgeries, cataract surgery, breast surgery, minor orthopedic or urologic procedures, thyroid surgery, most ambulatory same-day surgeries.
Got it. And the other bucket?
That covers intermediate and high-risk procedures. These have a cardiac event risk generally under 5%, but significantly higher than the low-risk group. This includes major operations like carotid artery surgery, fixing aortic aneurysms, even endovascularly, major head and neck surgeries, big operations inside the chest or abdomen, major orthopedic surgeries like hip replacements, prostate surgery, peripheral vascular surgery, and major aortic surgery.
So bigger operations, more stress on the body.
Precisely. And it's crucial to remember, emergency surgery is always considered very high risk. Doing the same operation emergently versus electively can increase the cardiac complication risk by 2 to 5 times. The urgency itself adds enormous stress.
That makes sense. How does knowing the surgical risk level change the pre-op approach?
It frames everything. If you're healthy and having a low-risk procedure, the pre-op evaluation might be quite minimal.
Right.
But if you're having an intermediate or high-risk surgery, even if you feel fine, we're going to dig deeper into your history, really pin down that functional status, maybe use those risk calculators we mentioned because the potential consequences are just higher. It helps us tailor the whole evaluation.
Okay, so this is where it all comes together. We've got the patient's history, the meds, the tests or lack thereof, the active cardiac conditions, the functional status, METs, and the risk level of the surgery itself. How does the internist, our mission controller, synthesize all of that to give the final go or no-go?
It's like putting together a complex puzzle, but luckily we have a pretty well-defined pathway, an algorithm, to guide us. It's very evidence-based now. Step 1, always. Rule out those active cardiac conditions. We talked about the unstable angina, recent MI, bad heart failure, etc. If any of those are present, stop. Postpone elective surgery. Address that first.
Okay, critical systems check first. Makes sense.
Right. If the patient clears that hurdle, then we ask, is the planned surgery low risk?
Less than 1% cardiac risk.
Exactly. If yes, and there are no other major unstable medical problems, then generally you can proceed to surgery.
Okay. What if it's not low risk?
Then the next question is about functional status. Can the patient comfortably achieve 4 METs or more without symptoms?
Climbing that flight of stairs.
Yep. If the answer is yes, they have good functional capacity, then generally they can proceed even with the higher risk surgery.
Interesting. So functional status can override the surgical risk level to some extent.
In many cases, yes. Good functional capacity is very reassuring. But if the functional status is poor, less than 4 METs, or if it's simply unknown, maybe the patient can't really tell us or can't exercise, that's when we often turn to a more sophisticated tool.
The risk calculator.
Exactly. Specifically, the NSQIP Surgical Risk Calculator. NSQIP stands for National Surgical Quality Improvement Program. This tool has largely taken over from older, simpler indices.
And what makes it better?
It's much more comprehensive. It integrates a whole host of factors: age, specific comorbidities, kidney function, the exact type of surgery planned, functional status, if known, many of the things we've discussed. It takes all that data and generates a personalized risk estimate for various complications, including MSE, major adverse cardiac events. It gives a much more precise, individualized risk percentage.
Okay, so you plug in the data, get a MAC risk percentage, then what?
Then we look at that number. If the estimated risk of MSE is less than 1%, generally okay to proceed. But if the risk is 1% or greater, that's the threshold where we might consider further cardiac testing, like a pharmacologic stress test. And this is key, only if the result of that test would actually change management.
Back to that principle.
Yeah.
Will it change the plan?
Exactly. There's no point doing a stress test if we're going to proceed with the surgery cautiously anyway, regardless of the result. It has to potentially alter our approach, maybe lead to medication changes, or even rarely consideration of pre-op intervention, though that's uncommon just for risk reduction. So this whole algorithm: check active conditions, assess surgical risk, assess functional status, use NSQIP if needed, provides a structured, thoughtful way to make sure we're preparing you as safely as possible.
It really is incredible. So much detailed assessment, all happening quietly behind the scenes before many of us even think about checking into the hospital. This deep dive really shows it's far from just a formality. It's a critical safety process.
It absolutely is, and it really highlights that partnership. The surgeon is focused on the technical success of the operation. The internist is focused on ensuring your body, as a whole system, is ready for that challenge. It's a great example of collaborative care.
So for you listening, the next time you or someone you care about is scheduled for elective surgery, maybe you'll have a new appreciation for this preoperative evaluation. It's this complex, personalized check happening to minimize risks.
And maybe it empowers you to ask questions. What's my functional status in MATES? Or if it's a higher risk procedure, what does the NFQIP calculator estimate my risk to be? Being informed helps you be a true partner in your care.
Absolutely. Which leads to a final thought for you to consider. How might a deeper understanding of all these preoperative steps empower patients like you to be even more active partners in making decisions about your health, well before you even see the inside of an operating room?